Okay, excellent. So, good evening. Thanks everyone for coming and welcome to this webinar on endodontics in special care dentistry hosted by the Irish Society for Disability and Oral Health. It's a first of a series of webinars for this year's ISDH cycle. So do tune in for future webinars that we have. We'll publicize it in the same way that we have been, in the same way that you've heard about this one. I also want to remind people to join our membership for access to the recordings of these webinars and a significantly discounted rate for the summer conference next year, which is bound to be a great one as per last year. So please do come and do visit us in Ireland, even if it's just for a holiday on the side. Few housekeeping. So there's a Q&A. You see a column at the bottom here, and there's little toggles that you can click. There's a Q&A at the bottom, so you can ask questions throughout the presentation. And what we'll do is we'll handpick some questions to be asked at the end of the presentation this evening. So please do, if anything pops up in your head during the presentation, please do jot it down and send it to us, and we'll aim to answer the questions at the end. I'd also highly encourage you to engage with the chat function that you see on the menu at the bottom, to share your experiences and your thoughts about certain topics that are raised. There will also be cases that the speakers will discuss where they would like you to share your thoughts on those cases. So please do engage using the chat function for those. And then you can also raise your hand for even more interaction. So if you have anything that is better vocalized instead of communicated through chat, please raise your hand during the cases or at the end of the presentation, and we'd be happy to ask you to unmute and you can share your thoughts verbally. And the last thing is there's a closed captioning function that exists, and you can toggle it on and off at the bottom if you wish. So without further ado, I want to introduce the plan today. So we've received a large amount of interest in this webinar, and of course it's no surprise, working with people with medical and intellectual disabilities, it's important that we're able to provide them with equal access to oral health care services and the different treatment options available like the rest of the community. And this means ensuring that we can offer services like successful root canal treatments. So we invited Dr. Shazia Kaka and Dr. Marie-Sophie Bogner to work in, who both work in the Sedation and Special Care Department of Guy's Hospital in London. And they're going to speak to us today about this topic. So Shazia is a consultant in special care dentistry, and if she doesn't have enough on her plate as being a special care consultant, she is just starting her master's in endodontics. So good luck to you, Shazia. And then Marie-Sophie completed her training in special care dentistry in Clermont-Ferrand in France and has come to London to spread her knowledge. Thank you. And she believes that nothing replaces a tooth like the tooth itself, and therefore does routinely root canal treatments and pulpotomies under sedation. So without further ado, I'd like to hand the stage over to Shazia.
Thank you so much, Ahmed. I'm just going to share my presentation. Excellent. So hopefully everyone can see that.
Yeah, we're good, Shazia. Thank you.
Perfect. Okay. So first of all, thanks so much, Ahmed, for inviting us to speak today, and thank you to ISDH for the opportunity as well. So my name's Shazia, I'm one of the consultants in Special Care Dentistry at Guy's Hospital, and joining me is my colleague Marie-Sophie, who is a specialty dentist in Special Care Dentistry. She was a specialist in France and joined us about a year ago now. So both of us are extremely passionate about endo in the context of special care. As a disclaimer, we're not specialists in endodontics, but we have both done further training post-graduation. So during the presentation, we will be sharing you some pictures of products and materials we like to use. Just to reassure you, we're not in any way sponsored by these companies and have no conflicts of interest to declare. So why is endo so important in special care dentistry? Well, we know that there is a lot of qualitative evidence to show that tooth retention has significant benefits on a person's quality of life. It contributes to function, nutrition, speech, aesthetics, and by virtue of all of these factors, it contributes to our overall general health, self-esteem, dignity, social interaction. And if we think about some of our special care patients who may already be marginalised, socially stigmatised, have difficulties talking or eating due to various disabilities, the ability for them to retain teeth where feasible and appropriate is arguably even more important. We are also living through a time where patients with chronic conditions such as cancers are living for a lot longer due to significant advances in medical therapies. Many of these patients will be currently undergoing treatments like high-dose bisphosphonates or newer biological therapies whose side effects are still unknown. And as a result, extraction may just not be the preferred option. And of course, whilst restorative care won't always be appropriate for these patients, we as special care dentists need the skill set to be able to more predictably and confidently know when it is appropriate and to help provide that care when it's necessary. So we hope today to be able to share with you some of our tips for providing successful endo in special care. We plan to discuss case selection, firstly, how to decide when endodontic therapy is required and what factors to look for in judging the likely success of treatment. We hope to increase your awareness of pulpotomy as a viable future treatment option in special care adults. We will also discuss potential challenges when doing endo in special care and provide techniques to help overcome them. So as a general rule, we may consider endodontics as an option for a patient if one of these 5 diagnoses apply. So either there's irreversible inflammation of the pulp or inflammation of the periodontium from a pulpal cause. When making a diagnosis, the gold standard is that ideally there should be 2 separate indicators that together point to the diagnosis. And usually this would come from a patient's history, our clinical exam, certain clinical investigations, as well as radiographs. In special care dentistry, however, we know that trying to attain any of these things can potentially be more challenging. Many of our patients are extremely anxious and may not respond reliably to clinical investigations. Many may have very limited communication, cooperation, or profound gag reflexes, and as a result, we need to work out alternative methods of coming to reliable diagnoses. Often, even trying to ascertain the presence of pain, never mind getting a pain history, can be difficult, with us being reliant on the observations of caregivers or family members. I'm sure many of you have come across some of these pain scales. They were predominantly developed for patients with advanced dementia, but nonetheless, they can be useful for patients with any cognitive impairment where independent communication is difficult. So essentially, these scales rely on a person's non-verbal body language and their general behavior to indicate pain, with some, such as the first one, being quite specific to orofacial pain. So these are the questions I tend to ask caregivers to help ascertain the presence, possible location, and type of pain in a patient who cannot communicate easily. So have there been any changes to eating and drinking habits? Specifically, have they been refusing food that they otherwise wouldn't? Or have they avoided certain types of foods, so very hot, cold, chewy, or hard foods? Have they kept food pouched on one side? Have they resisted toothbrushing more than usual, or are they wincing, grimacing, or pulling away when brushing any specific part of their mouth? Have they been holding, pulling at, or even punching their face in a particular area? Has there been a general change in behaviour, or have there been any observed swellings or extraoral changes? If the patient's in a hospital or a care home, sometimes an increase in respiratory rate, heart rate, or periods of hyperventilation may also, potentially with other signs, indicate pain. Now, of course, we ideally want to supplement any pain information we can get with a clinical and radiographic examination. And if cooperation is very difficult, we may need to consider sedation for this. I often find that these sort of diagnostic sedation appointments are really helpful, not only to help us sort of ascertain a better look, but also to assess that patient's sedation response, so that if endo is an option for them, we can then judge its feasibility under conscious sedation. In terms of radiography, we have a few different options available to us to try and aid pain diagnoses. So if you've got quite a vague pain history, so we all know the patient who comes in with sort of pain everywhere, they're really anxious, they can't localize it to any specific tooth, and most of the time they have a very heavily restored dentition. So OPGs can be really helpful to isolate potential causes of pain. Nowadays, many OPG machines can do extraoral bite wings, and these are particularly useful for patients with gag reflexes or limited mouth opening. So although they're not as good as standard bite wings, they do avoid the overlap that you'd get in a usual OPG. If cooperation for an OPG isn't good enough, we can consider lateral obliques. Admittedly, not the best pictures due to superimposition of anatomy, but can certainly help us visualize large carious lesions or pathology in posterior teeth. Often we see patients with chronic pain syndromes who are more likely to present with atypical facial pain. And increasingly, CBCT is very well recognized and accepted as an investigation to exclude odontogenic causes of pain. And often, to be honest, when we do CBCTs, we do sometimes find things that we really don't expect. For endo, periapicals are of course the gold standard, but if patients find these hard to tolerate, you can either consider using a smaller pediatric film or using the larger X-ray, but in a vertical rather than a horizontal pane. Other possibilities for anterior teeth are upper or lower standard occlusals. So obviously, once you have your diagnosis, you need to be able to assess the actual practicality of carrying out endodontic treatment. This was an index produced in 2017, and essentially it highlights 4 key areas that we should be looking at before embarking on treatment. So there are 3 restorative categories: structural integrity, periodontal, and endodontic treatment need. And these are specific to the tooth that you're thinking about treating. And then there's one more general category, which looks at the overall context of the patient, which of course is particularly important in special care. Now, essentially, when we talk about structural integrity, we're looking at how much remaining sound tooth tissue there is. So is there enough to be able to get a rubber dam on? And once we've done our endo, will there still be enough for a predictable restoration? The European Society of Endodontology, they do advise that all root-filled premolars and molars which have one interproximal wall missing should ideally be restored with a cuspal coverage restoration. So we need to try and assess whether that will be possible before carrying out the endo. For an indirect cuspal coverage restoration, ideally there should be a minimum height and thickness of 2 millimeters of sound tooth tissue all around the tooth. And in addition to that, you're looking for another 2 to 3 millimeters before the hip bone to ensure that you're not encroaching upon the biological width. Things are changing, however. So some of you may have heard of the concept of deep margin elevation. And essentially, this allows you to relocate your indirect restoration margin more coronally, finishing it on composite rather than tooth. So we can see here that we've got a deep distal subgingival box, which has been restored with composite. And rather than finishing the onlay margin below the composite, like we once would, it's actually been finished 3 millimeters coronal to the composite margin, which does make prepping and impression taking a lot easier. In the grand scheme of things, this is a newer technique, but over 12 years, the literature does report good success rates, which are close to 95%. Onlays, now much more commonly used than crowns, obviously because they are adhesively retained, we can avoid that unnecessary removal of tooth tissue that once would have been required for crown retention. There are a number of different materials available, each which has different preparation requirements. My favourite, as long as it's not right within the smile line, is semi-precious metal, just because it hardly requires any prep and it can be nicely burnished with the margins. Lab-made composite can be used. These do tend to wear more. They also produce more marginal discoloration and they're generally less resistant to fracture.
If your tooth has only one remaining coronal wall, that's when it's usually suggested to use a post. So traditional posts are mainly used for incisors now because you have potentially better option for molars and premolars. For example, endocrowns. We're going to talk about endocrown just after. So compared to the traditional post, the fiber post system uses all the advantages of adhesion, so you can make your post shorter and it reduces the risk of fracture or perforation when you prepare your tooth. Yep, next. Oh, and just a slide before, Shazia, sorry, I forgot to say, so that's the system that we use in our department, so that's the Real IX, and to illustrate the fiber post, here is a case of an endo with a fiber post and a crown that was done in a single visit for a patient with learning disability. Thank you. Now, if you have a molar or a premolar and you did a root canal treatment, you can also restore this tooth with an endocrown. So that's how it should look like at the end of your preparation. The endocrown using the space created by the pulp chamber for micromechanical retention and adhesive cementation for your micromechanical retention. So I'm not going to explain all the steps to prepare an endocrown, but I added a reference that really nicely explains the step by step. So I invite you to just have a look. As I said, that's how your tooth is supposed to look like. If you're lucky enough to have the digital scanner, it's great for your impression because the comfort of your patient is going to increase and the gag reflex, if there is any, is going to be reduced. And of course, also, if you're lucky enough to have and be able to work with an appropriate lab, everything can be done in the same session, your preparation, the design, the milling, and the bonding of your endocrown. Next slide. It was really important for Shazia and me to show you what option can be available, especially the new techniques, but we recognize that in special care dentistry, resources can be limited, resources for the patient and also resources for the practitioners. So another option that you can consider is cuspal coverage options. So that's, for example, the direct cuspal coverage option with composite. So the idea is that you want to reduce your cups by 3 millimeters and recreate your cusp with composite. So it's like a non-lay, but it's shear side. It's so long term, it's maybe not the most optimal option, but it's certainly better than only just one composite without any cuspal coverage. Another option that you can consider is also stainless steel crowns. So I'm sure that you maybe more use of stainless steel crown in children, but it's also indicated for adults. It's usually considered more like a temporary solution, but long term, it has very good success rate. It has the advantages of not having to deal with the lab. It's cheaper. It's able to recreate good contact points, and occlusion. It also prevents the risk of secondary fracture. And again, the cost is also, it's just limited. So think also of this option.
So we're just going to go on to the second restorative category of the dental practicality index, which was the periodontal status of the tooth. And of course, there are a number of things that we want to consider. So firstly, are there any deep pockets? Now, obviously, if there are generalized BPEs of 3 or 4, ideally, we do want to try and attain some periodontal stabilization before carrying out endodontic treatment. Clearly, achieving optimal oral hygiene can be more difficult for some patients due to associated impairments. There's no threshold above or below which you can or can't go ahead, and it really does depend on other factors and your own clinical judgment. As a word of warning, if there is an isolated deep pocket which is specifically localized to that tooth, it is highly indicative of a root fracture and does significantly reduce the tooth's prognosis. In terms of mobility, we can expect a little bit of mobility in a tooth which has apical periodontitis, but grade 2 or 3 mobility in a tooth which also has significant vertical or horizontal bone loss or more advanced furcation defects is a lot less likely to do as well. And of course, we need to look at the ease or difficulty of the actual endo. So if the tooth is rotated, tilted, crowded, we know that isolation and access into the pulp chamber may be more challenging. And unfortunately, this is more likely in special care patients who often do have malocclusions and crowding. We should also assess whether the pulp chamber and root canals are visible on an X-ray. We know that patients with syndromes such as Ehlers-Danlos loss, Marfan's, as well as those with end-stage renal failure, are known to have a much higher frequency of calcifications and pulp stones, potentially making access and canal location more difficult. Older adults are more likely to have sclerosed canals. We can see on this lower left 4 that there is a canal, but it's extremely narrowed with almost complete loss of the pulp chamber. The degree of root curvature is also very important. This lower left 4 actually belonged to a patient who'd had a previous history of head and neck cancer. So as expected, I got into the canal fairly easily, but despite using a size 8 or 6 file, I was just unable to gain apical patency. Every time I took the files out, I could see that there was a really significant and acute distal curvature at the apex, which in the end, I did need some help from the specialist with. This upper right 4, as well as curving, actually bifurcated at the point that the canal disappears, making it a lot more difficult to treat. The shape of the canal can also vary. We know that there are a number of genetic syndromes that have slightly wider canals, S-shaped canals, or short root canals. As well as short, they can also be very long. So this was a patient who'd had multiple doses of Themeta for multiple myeloma and needed a reroot treatment of the upper right 3. The canal was 31.5 millimeters, and seeing as our instruments only go up to 31, it logistically made cleaning and preparation possible, but difficult. What's the size of the apex? We know that patients with learning disabilities and epilepsy are more likely to suffer trauma, and as such, they do have a much higher prevalence of immature roots, which again can be more technically challenging due to the risk of extrusion. And of course, as well as all these dental factors, we have to acknowledge other potential challenges of doing endo in special care. This is from the American Association of Endodontists, and we can see that pretty much every single one of these that makes endo more difficult is relevant to special care patients. Medical history may have impacts in terms of reduced ability to cope with long appointments, limited mouth opening, difficulty achieving anesthesia. If patients were to require antibiotic or factor cover and we're doing multiple stage RCT, we need to weigh up the advantages and disadvantages of potentially giving cover multiple times versus an extraction that can be done over one visit. We also need to look at patient cooperation and compliance. If they need sedation, is their sedation response adequate? If they need GA, can we justify doing root canal? And of course, this isn't a simple question. We need to think about a lot of things. What tooth is it? What impact will it have on the patient if it's lost? How predictable is it to root treat in one appointment? So for example, if it has a chronic sinus or a large periapical radiolucency, I would almost always opt for a 2-stage RCT, which just isn't possible under GA. If it was to fail post-GA, is there a backup option to provide extraction which doesn't involve another GA? We need to consider the patient's overall oral health. If they have generalized caries, perio, poor oral health habits, are they motivated to improve? If as part of a treatment plan, we're already extracting multiple other teeth and providing a denture, does it potentially make more sense to add the tooth on? Or perhaps it's a strategic tooth, which may help with the stability or retention of a denture. And lastly, although we never like to have to bring this into the equation, we do have to use our limited resources wisely. Now, in the knowledge that root treatment can be costly, resource heavy, time consuming, often require multiple appointments, and in some cases can be technically demanding, Marie-Sophie is going to talk to you about a newer option that could be used in certain cases.
Thank you, Shazia. But before continuing the presentation, we just wanted to ask you some questions. So here are 3 different preoperative X-rays, and we just would like to know what you would have done for those cases. So the first patient, what would you plan a treatment under IV sedation for patient with learning disability. You want to treat the upper right 6. You're not sure if there is any symptom because the patient don't really communicate if there is any pain. The second case, number B, on the lower right 6, is a patient that has Ehlers-Danlos syndrome, gag reflex. You did a filling, but now the patient is coming back with irreversible pulpitis. You planned a treatment under inhalation sedation, but what kind of treatment? And now for the lower right 7, in a 17-year-old man with dental anxiety, what would you have done? So that's just some question, and we're just interested to know what would you have done?
If people can write in the chat, that would be great. Thank you. I suppose I can start while people are writing away. The last one, the lower right 7. I imagine after the caries removal, there'll be very little tooth structure left, and I think they're young, and I also see that the 6 is on its way out, unfortunately, as well. Maybe potentially extract and allow for the 8 hopefully to come in because they're young. Then for the other 2 cases, it's a little trickier because they do look restorable, and so provided compliance is there, you might consider something like a pulpotomy or a root canal. But yeah, we have lots of other comments here that are, I'm sure, a lot more correct. So I have people saying they would. I mean, can you guys read the comments?
I'm just looking at the same
Okay,
time.
perfect.
It's really interesting to see all the comments, and your answer is very, very interesting, Ahmed. So so you would choose your treatment option with the resources that you have, but just to let you know that for all those cases, we didn't do any root canal, we didn't do any extraction, we did caries removal, yes, but all those teeth finished with a full pulpotomy. And it's really funny, Ahmed, what you said about the extraction. So just if I have to carry on, so a full pulpotomy is an endodontic treatment, but not a root canal treatment. It's a technique that consists in the removal of the coronal pulp to keep the radicular pulp vital. So a full pulpotomy can be indicated for teeth that are in irreversible pulpitis, or for patients who have decays that are very close to the nerve, and you don't want the risk to re-intervene after caries removal. You don't want your patient to come back with postoperative sensitivity or irreversible pulpitis. If there is any pulp exposure and you have your tooth that's vital, you don't have to do a root canal treatment. You don't have to do an extraction. You can also think of the full pulpotomy. I added a screenshot of a webinar that you can access through the ISTH website that explain different techniques to try to keep your tooth vital. So I'm not going to give all the details, all the available options. I'm really going to focus only on the full pulpotomies. So now how do you do a pulpotomy? So I chose this case that was done under intravenous sedation, also because I know that for some patients, the restorability of the lower left 7 can be questioned. And it's also for me a way to show you how this tooth was restored. So before a pulpotomy, you really want to make your tooth numb, and it's really essential that you put the rubber dam on. And that's really what I would advise for every filling that you have to be done, especially if it's close to the pulp. Just put your rubber dam on. So in case there is any pulp exposure, don't worry, there is not going to be any bacterial invasion. You're completely safe. So you remove your decay, and that's what you see in the different pictures, and you have pulp exposure. And at this stage, if you see that the pulp is bleeding, it means that your tooth is vital. So even if it's a patient who couldn't communicate any pain, but you've seen there were no history of swelling, and the tooth is vital, that's a way to know that the pulp is not infected and that you can carry on with your treatment. So you open your chamber. You want to achieve homeostasis, and that can be achieved by cutting the radical pulp with Gase-Glidden burst, and I usually use a Gase-Glidden number 3. It's really important that you irrigate with sodium hypochlorite to avoid any bacterial invasion. And that's the different steps that you have to follow. So to open the chamber, I would use a Z-bus and the Gase-Glidden 3 to achieve homeostasis. Now that you are at this stage, you want to fill your cavity with a material, but which material can be used for full pulpotomy? You have different options. The gold standard is to use tricalcium silicate, so for example, biodentin. It's widely studied and used. It's biocompatible. It prevents bacterial contamination with good sealing properties. You can bond composite just right after. The only problem is that it has a long setting time. Biodentin needs 12 minutes to set, and it has a high cost. So an alternative to biodentin is to use, for example, zinc oxide and eugenol, for example, RRM. It's not biocompatible. There is no bonding with the dental tissue, so you have to do a coronal restoration right after your pulpotomy. So don't temporize. You have really to finish with a definitive restoration. It has a quick setting time, and the cost is low. So under GA is, for example, a good option. So to continue the case presentation, so in this case, I put some biodentin, and while I was waiting the 12 minutes to avoid having to lose any time, I just put my rubber dam on the side, and I did the extraction of the lower right 6. So that's a way just to not waste any time, especially when you're under sedation. You don't want to repeat too many appointments, so you can optimize your treatment session in this way. After you put your biodentin or your RRM, you want to remove the excess from all the walls and put a hermetic restoration of the tooth. So before removing the rubber dam, I put some GIC, and then I did a preparation for stainless steel crown, and that's how I restored this tooth. Not with an endo crown, not with cuspal coverage, but with the endo crown that was sealed with 2 Fuji2 and 1 Fuji9. So I know that a root canal treatment is something that can be scary, and maybe that's why you're here tonight, just to have some tips and feel more confident. But Shazia told you also that root canal treatment is something more complex and it takes more time. So think of pulpotomy. If you have a decay close to the nerve, if you're not sure if there is any symptoms, you just remove your decay you have your pulp exposure, if the tooth is bleeding, don't put any file in your tooth. Just open your chamber, achieve homeostasis, put biodentin REM, and restore it in a definitive way. And I think that's what I when I continue. So, but either if it's a root canal treatment or a pulpotomy, you really want your tooth to be numb. So that's going to be also very important to achieve a good local anesthesia. In special care dentistry, there are non-resistant to LA, for example, for patients who are anxious or have Ehlers-Danlos syndrome. So it has been proved that articaine is usually the best option. Don't be scared you have to make it numb, unless there are some contraindications. For example, don't do ID blocks if there is blood thinners. And for patients who have infectious endocarditis, it's not always recommended to do intraligamentary infiltration. But for all of the patients that you're going to see, just really make it numb. Don't be scared. I would suggest right away start with 2 ID blocks if it's a tooth that's on the lower molar, 2 ID blocks, 2 buccal infiltration. So you know that you're going to be, you're not going to lose your patient cooperation. Next slide. Next. Okay, thank you. So another feature that's going to be common for root canal treatment or pulpotomy is to be under rubber dam and that you achieve a good tooth isolation. So we know that our patients sometimes can have tricky anatomy. So think of wedgets and of flexidam. Flexidam has also the advantage that you don't have to put it in the fridge, so it's much more easier. You have lots of different techniques to put the rubber dam on. That's the technique that I'm using. So I don't know if the videos are working, but one video is supposed to show how I just punch just right in the middle of the frame. And if it's a molar, lower molar, I put my clamp opposite of the frame, and if it's not, just same direction as the frame. And if you're under intravenous sedation and your rubber dam is over the nose, of course, you want your patient to keep breathing, so you just retract your rubber dam just to clear the nose. So that's maybe more an artistic way how I did it, but that's just the technique that I use. And putting the rubber dam shouldn't take long. Maximum, if it should be put in 15 seconds, so you don't lose time to put your rubber dam on. Thank you.
Okay, so whilst pulpotomy is an excellent option for the vital tooth, there are of course still going to be some patients where we can't get away with that, and then a root canal treatment may be an option. So I'm going to talk to you a little bit about access, just because it is the most important part of endodontic treatment. And there are some laws that we can keep in mind to try and increase predictability, especially if from the X-ray, it looks like you might encounter slightly abnormal anatomy. So law 1 is the law of centrality, which states that the pulp chamber of every tooth is in the center of the tooth at the level of the CEJ. So if you line up your burr from the occlusal surface of the tooth to the CEJ, you automatically know at what depth you should approximately feel that drop into the pulp chamber. Now, obviously, if your pulp chamber is very calcified or if it's not visible on an X-ray, you may not feel that drop, but it's nonetheless useful to have a reference point of where it once would have been and work forward from there. As well as measuring the distance on the tooth, I will always also measure the distance on a radiograph from the cusp tip to furcation and cusp tip to pulp floor. And obviously, if you're drilling within these two distances, it's time to reevaluate because you know that you're not in the right place. So the second law is the law of concentricity, which basically states that the walls of the pulp chamber are concentric, or they follow the external outline of the tooth at the level of the CEJ. And it's the last bit, the level of the CEJ, that's important because we know that the shape of the occlusal surface may not always correspond to the shape of the CEJ. So with a perio probe, I will initially go around the tooth and by tactile feel, identify if there's a bulge or narrowing of the CEJ in any direction, because you know you're likely to either have to extend or narrow your access cavity in that direction. The third law is the law of colour change, which essentially states that the colour of the pulp chamber floor is darker than the cavity walls. So pulp chamber is sort of a grey colour, whereas the cavity dentine is sort of more yellow. And although it can be a little bit tricky to see this without a microscope, you know that circumferentially, if you can see that light-dark junction, your access is complete. In terms of what burrs to use, it really is personal preference. I tend to start with a 710 burr, which is the first one on the left-hand side. Once in the pulp chamber, I will de-roof with an endo Z burr, and then I'll remove any residual undercuts, calcifications, or pulp stones with either a gooseneck burr, or if you are lucky and have an ultrasonic, that's the one to go for. So pulp stones and calcifications, they look like very sort of white areas within the pulp chamber, and underneath them, there are often canals. Obviously, in every tooth, there is an average number of canals, but there can, of course, be less or more. So to give yourself the best chance of finding all of them, you want to consider the law of symmetry. And this states that apart from maxillary molars, canal orifices are always equidistant to a line drawn in a mesial distal direction through the center of the pulp chamber floor. So say in a second mandibular molar, if you found your distal canal was positioned very lingually or very buccally, or when you place your file in the canal, it's not really positioned in the long axis of the tooth, it would then be important to look for another canal, either buccally or lingually, wherever you've not found the first one. When looking for your canal orifices, really focus on that junction between the pulp chamber floor and the dentine walls, because that's where they're most liable, that's where they will be. Obviously, your main aim once you're in the canal is to remove necrotic or residual pulp tissue, whilst preserving your original canal anatomy and creating sufficient space for your irrigant. So I will generally enter canals with a size 10 file, tends to be the perfect combination between flexibility and rigidity. Obviously, if your canal is really narrow, you may want to consider a size 8 or even 6 file. And if it's really wide, you may want to consider a larger file. So you want to flare coronally and then explore the apical third. So if there is resistance when you're going into the apical third and it feels quite spongy, you can use your normal stem winding, which is 20 degrees one way, then 20 degrees the other way, or your balance forces to try and advance that file apically. If your file reaches a more hard stop, a little bit like a brick wall, you do need to be a bit more careful because forcing that file may actually cause ledges. If you do come across a very hard stop, look at your X-ray, see if there are any curves, think about pre-curving your file to get across those curves. And I normally do this with a shorter, sort of 21mm instrument to give you a lot of better tactile feedback. Obviously, throughout this, you want to use continual irrigation. Hypochlorite is best. But if you're sort of struggling to get through sort of debris or spongy resistance, a bit of liquid EDTA, and also these seed pilot files can be really helpful. So these seed pilot files are a bit more rigid compared to K-flexor files, so they can get into sclerosed canals a lot, so calcified canals a lot easier. And once you've got to your working length, especially if it was difficult to get there, leave your file in place, and about 100 times you want to go vertically up and down by about 2 to 3 millimeters until the file is super duper loose. So this is something I got from an endodontist, but I have that constant saying in my mind, super duper loose. So a size 10 file that can be passively manipulated to the working length and is super duper loose represents a really good glide path. And you're then ready to use your rotary systems. Now, rotary is a bit overwhelming in that there are over 200 different file systems on the market, and each one is just slightly different in some way. So which ones do you use? I do use different file systems according to the case. Just because it is the most widely available in our department, I use ProTaper Next a lot, but I do tend to limit it to straight and easy to manipulate root canals because the files are quite stiff. ProTaper Gold, another good option, slightly more flexible, so can be used with slight curvatures. It also contains this really lovely SX file, which is a orifice opener, so it's got a similar function to Gates, Gliddon's burrs, but really, really helpful in producing a coronal flare to help get your irrigant down. Patients with limited mouth opening, where it's difficult to get straight line access, Wave 1 Gold is a really good option. Very flexible, so it can be sort of pre-curved before insertion into the root canal, and then once in the root canal, it changes shape to follow the shape of the canal. It is also classed as a single-use system, so the red or the primary file, which is the second one down, by itself is sufficient in 80 to 85% of cases. So this is just a video to show you Wave 1's flexibility. So as you can see, I'm just bending that and it just very, very nicely kind of stays in place. And honestly, it's really, really difficult to break these. Obviously, it's possible, but it is pretty difficult to break them. There are a number of other file systems out at the moment that show a lot of promise in terms of strength, flexibility, and dentine conservation. So if you're thinking about investing in any new systems, do have a look at all of these.
Shazia already discussed a little bit the problematic of limited mouth opening. Obviously, some mouth opening are so extreme that no treatment is going to be possible, even root canal treatment especially. So things that can be helpful include pre-curving hand files, using flexible file system, reducing the coronal height of the cuffs, and if the mouth opening is due to fatigue or T&D issues, then mouth prop or sedation can help. In this video, you also see a technique how to insert your file by retracting your rubber dam from the palatal side. That's also a technique that can be used. So just be mindful how you're going to insert your file. So not going from buccal to palatal, but more you retract your rubber dam just to enter your pulp chamber more easily. Another challenge that you can face when doing endodontic with special care patient are gag reflex. So there is a very nice video that you can find again on the ISDH website that explained how you can how to manage gag reflex. It's a video that lasts 1 hour, so we're not going to give all the details again. So just a quick summary: you can use acupuncture, you can use sedation, use some small films. And CBT is also an alternative, an option that you can think of if you have access to CBT.
So we're going to just talk a little bit about obturation as well. Again, lots of different systems available, and no one system is always going to be better than another. Ultimately depends on the case, what you have available, and what you feel comfortable with. Because there are lots and lots of different variations within and between techniques, I'm not going to go through all of them, but I will just talk about the ones I most commonly use. So single cone technique, really, really, really straightforward technique, where essentially a gutter perk point that specifically corresponds to the shape and the taper of the last rotary file you use during preparation is placed in the canal with sealer for obturation. So very time efficient, not technique sensitive, but it does have the significant disadvantage that trying to achieve a 3D seal is virtually impossible. So you'll end up having lots of unfilled canal space. To try and compensate for this, you can now use these bioceramic sealers. So I use the one shown, Wellroot SD. Unlike more conventional sealers, they don't dissolve over time, and you can use a lot more of them. So these techniques, rather than being called single cone techniques, are actually now called sealer-based obturation methods. So you would initially fill your canal with sealer using the syringe, then you'd place your GP point in, and together that helps to produce a more 3D seal. Cold lateral condensation, I'm sure a technique that you're all very familiar with. It's obviously been around for a long time. It has got good success rates, isn't hugely technique sensitive, and doesn't require any expensive equipment. But again, it can be difficult to produce that 3D seal. To try and overcome that challenge, you can use heated spreaders such as the one shown rather than sort of your cold spreaders. And these heated spreaders basically melt the existing GP in the canal, so it allows space for more cones. This is the technique I tend to use the most. It does require investing in some pieces of expensive equipment, but at the end of it, you should have a much denser, more compact filling that flows into canal irregularities, lateral canals, and abnormally shaped systems. I won't go through this technique, but really simplistically, this system B is basically a heat source, and it comes with a tip. So the tips are basically plunged into your gutta-percha cone, about 5 to 7 millimeters from the working length. That causes a coronal GP to break off. Using the coronal space that's left, you can either place a post if that's appropriate, or you can backfill that space with liquid gutta-percha using an obturer gun, such as the one shown. And so as we can see, it does produce generally some really lovely results, but there are some disadvantages. So it is more time consuming, it is more technique sensitive. It does use high temperatures. As you can see, this gun is 230 degrees Celsius, which for certain patients who may unpredictably move or have limited mouth opening is just not appropriate due to the potential risk of burns. Because it does also require quite a lot of downpacking pressure, there is a risk of extrusion with this technique, especially if the apex is large. And we can see in that last X-ray that that's exactly the thing that happened with that lower molar. In fact, if the apex is larger than a size file 50, we really should ideally be considering the use of calcium silicate cements. And the reason why they're so appropriate in these situations is because firstly, they're biocompatible. So if they are extruded, it doesn't matter. They're also radiopaque, bacteriostatic, and they are bioactive. So they can actually promote the formation of a dentine bridge. Again, they can be quite technique sensitive. For the purposes of time, I won't go through the full procedure. These slides will be available to you. So the technique is written on here. We more and more are coming across patients who are either at high risk of hemorrhage or osteoradionecrosis, and we know that the ideal situation is to try and avoid extraction if we can. So this was a 59-year-old male with a history of a left-sided squamous cell carcinoma of the parotid, treated with a parotidectomy and post-operative radiotherapy. When I saw him, had limited mouth opening and was at very high risk of ORN in the upper left region where he'd had a very hefty dose of radiotherapy. He was in pain from his upper left 7, and looking at the PA, I was quite suspicious of this appearance. I wasn't sure that it was caries. And opening up the tooth, there was this very, very extensive resorption defect with proliferation of the pulp. Once I'd finally stemmed the bleeding, I and an endo colleague tried to repair the defect with biodentine, but it was extremely challenging, and we couldn't be sure that we'd gained a good seal. As a result, I wasn't that happy to use hypochlorite. So at this stage, I knew firstly because I couldn't use hypochlorite, and secondly because I didn't have a great seal, the chances of the patient getting future symptoms were going to be higher. If they did get future symptoms and I had obturated the tooth, it would be really difficult to know where to go from there. So instead, I have decided long-term to just leave these canals dressed with calcium hydroxide. And since then, I have overlaid this tooth with composite. I appreciate that leaving a tooth just dressed with calcium hydroxide is pretty unconventional. Probably my endo colleagues wouldn't love this, but I at least know that if or when the patient does get symptoms in the future, I sort of have a get out of jail card, and I at least have the option of redressing with calcium hydroxide. So finally, we will just talk a little bit more about the use of conscious sedation and GA for endodontics. Obviously, as special care dentists, conscious sedation is a technique we rely on very heavily to facilitate treatment for our patients. When doing endo, I would say 97% of the time I use basic conscious sedation techniques, so inhalation sedation with nitrous oxide and oxygen and IV midazolam. The great thing about inhalation sedation is that it's given continuously, so it's particularly useful for longer procedures such as endo because it never runs out. Additionally, you can alter the dose during the procedure depending on the patient's specific anxiety. So if they're more worried about LA or drilling, you up it for that point and you can reduce it for other bits. Sometimes if the mask does sit quite low on the upper lip and you're treating upper 2 to 2, it can get in the way of local anesthetic administration, in which case I just infiltrate slightly to the side and then recourse my needle once in the tissues. You might also find that during X-ray taking, you can actually slightly see the mask as per this X-ray. Makes it look sort of slightly hazy, but not undiagnostic. In terms of IV midazolam, obviously it has a more pronounced sedative effect than inhalation sedation, but it does have some disadvantages. So we know that with IV midazolam, you're titrating up to a certain point and then you're operating during that patient's recovery time, which does differ for each individual patient. If they have a long sedation window, you may not need to worry about top-ups, but more often than not, during a 90-minute appointment, I tend to find that I need to. So the key to top-ups, I find, is to administer them preemptively rather than reactively. And this is when, if you've done a previous sedation for that patient, it can be really helpful. So say last time their sedation window was 20 minutes, I would be thinking about topping up sort of 1 or 2 milligram a couple of minutes before that to keep them at a nice, comfortable level. The problem with topping up reactively is that you never really get to the level of sedation you were initially at. Sometimes for more difficult root canals, you can use a separate operator sedationist technique so that one person can completely focus on the dentistry, the other person can completely focus on keeping the patient comfortable under sedation. Managing patient expectations, also important. So I tell all patients who want midazolam for endo that because it's a long procedure and because midazolam has a restricted working window, there may be certain points where they will feel more awake and more aware. The other drug we tend to use quite a lot for endo is propofol. It is an IV anesthetic agent that can be used in lower doses for conscious sedation. It's given via a continuous infusion, so just like inhalation sedation, it's particularly good for longer procedures because we know it never runs out. It does have a much shorter half-life than midazolam, so when the infusion is switched off, recovery is very rapid. Patients do often appear slightly less sedated than with midazolam, and they can generally remember a little bit more, but nonetheless, most of them tend to be very well anxiolized. In terms of disadvantages, respiratory depression does tend to be more profound, and there can be some direct cardiovascular effects. There is also conflicting evidence on whether propofol may precipitate seizures, and if that was to happen, there's no reversal agent. So essentially, it is an advanced technique. It requires further training. It requires a separate operator and sedationist, and we do need to be more careful about the type of patients that we give it to. This was actually a 20-year-old female with severe dental anxiety. We attempted treatment on a number of occasions with midazolam, but she exhibited a really poor sedation response and she wouldn't accept inhalation sedation. She had this upper left 3, which she was really keen not to lose. It needed a root treatment. And although we did consider GA, because she also had a few other fillings that need doing, we thought, let's try propofol first. So we started with the fillings just to assess the sedation response, which was absolutely beautiful. And unfortunately, although I don't have the post-op, it was a very happy ending where we ended up completing all her treatment, including the root canal, with propofol.
General anesthesia is also an option to do sedation. It's not a contraindication for root canal treatment. The outcome of root canal treatment under general anesthesia are very good, and it's usually the same as root canal treatment done without GA, and sometimes even found better. But of course, you're going to have to face more challenges because of the ergonomical difficulties that you will have to face. There is orotracheal intubation that you will have to manage, operating time limitation. So if you plan to do root canal treatment, you know that it's going to take a little bit longer. So you have to discuss it with your anesthetist. The supine position of the patient means that your axis can be different. So you need to be mindful about it. And of course, equipment, X-ray, are they available on the GA? Is the equipment that you have, resources? That's questions. But there is always solutions. Someone told me there is no problems, there are always solutions. The solutions that you can think of are, for example, to have portable X-ray machines. So that's some example of what exists, what that you can buy or order. Again, we really want you to make your life easier. So if you come with lots of different files, it's going to be complicated and be realistic. It's not always easy to bring all the equipment in the GA. So if you can bring just the one file system like the Wave one, it's going to be much more easier. Another technique for obturations that we can talk about, if you don't have access to the techniques that Shazia described, think of, for example, the thermocompatible compaction. So that's also the MAC spanning technique. So essentially, the idea is that you produce friction between the GP and the internal walls of your canals, and that's how your GP is going to thermoplastify. So you get a 3D obturation, and you don't need to have big equipment like the System B or the Obtura. So, well, I think that's almost the end of the presentation. So if we just have to do some summaries of what we said, it's really important, I think, that you know what you're going to expect before starting root canal treatment. So look at your tooth, look at the X-ray, think of, are you going to face pulp stones or calcifications, so you can be ready. And when I'm writing be prepared, it's also to mean that be prepared before you start your treatment or your sedation. Make sure that everything ready, make sure that the battery, that all your equipment has battery. And that's a picture of a room with lots of equipment for root canal treatment. It can be quite overwhelming. And if you ask this to all your nurses, maybe they're going to hate you at the end. So just make your life easy. Just think of really what you need. And if, for example, you plan to do a pulpotomy, that's the box that I just have. It's just simple. I just have the burrs that I need, and it's less overwhelming. But for the rest, it's also really important that you remember to make it numb so you don't lose your patient cooperation. Don't underestimate your access cavity. With a good access, it's going to be much more easier to do your root canal treatment. If you open your chamber and the tooth is vital, so you see the pulp bleeding, just stop. Don't put any file in your canals. You can change your plan and do a pulpotomy, which is going to be much quicker. And the GA, the time, if you ask me, so for pulpotomy with stainless steel crown, we always plan 15 minutes. If you have to do your root canal treatment, think of your axis. Also a secret, just good irrigation, a lot of irrigation. You can use EDTA and sodium hypochlorite, just a lot to make sure that all the bacteria are eliminated. Think of your final restoration from the start of your root canal treatment. There is no root canal treatment without a final restoration. And also just practice, because you're going to be much more confident. With practice, you're going to be faster. And also special care dentistry is also time management. You are sometimes under sedation. You have a specific time limitation, so you just want to focus on what you need. So just at the end, you practice, you know what you're doing, so just do it. And during root canal treatment can be really rewarding because you never know how your tooth is going to heal, and that's different cases that are quite interesting. And the case at the bottom is quite a good summary of all this presentation. On the lower right 7, you can see a pulpotomy with a composite restoration. On the lower right 6, it was a root canal treatment restored with a a stainless steel crown, and on the lower right 5, a root canal treatment with a fiber post and composite. And those 3 tips I treated them under inhalation sedation is only one technique. So it's possible. It's possible to think of alternative solution and not think of extraction right away. And I'm sure that with Shazia is going to agree with me. We're really happy if you want to share your cases with us, if you have any questions, if you want to know if it's suitable for endo or pulpotomy. So that's our email addresses, and we would really love to hear from you and have some feedback. I think we're done.
Fantastic. Thank you very much, guys. That was wow, it was it was a lot of information in such a short amount of time. I think what you did between you was incredible. I think Marie-Sophie, what you did was kind of smash the ceiling of opportunity in terms of the different treatment options that we can provide our patients, from pulpotomies to stainless steel crowns. And Shazia, thank you so much for revealing all of the little secrets of a successful root canal, and all the little golden nuggets that you kind of provided. And thank God this is recorded, because I imagine I'll be going back over what both of you said before starting any tricky endos in the future. So thank you very much. There has been lots of questions coming in, and if we can try and go through as much of them as possible, maybe in the next 5 to 7 minutes, that would be great. So the first question is, will there be any trouble with occlusion in stainless steel crowns in adults due to the different tooth morphology?
No, before you're going to seal your stainless steel crown, you can try and you will ask your patient to bite together so you can check your occlusion. My recommendation, and I was looking at the question, I knew that one of the questions was, how do you prep a stainless steel crown? So if you go back on the slide, you're going to see a reference that also explains the different steps. So the idea is that you really want to strip your tooth, so all around your wall, and you reduce your occlusion from at least also 2 millimeters. So you're really it's going to be a short tooth at the end, and you try your stainless steel crown on. You don't want it to be too big, you don't want to be too small, so it just has to fit. And if your patient is able just to bite together, you can check just the occlusion. And if it's too high, then you have to reduce your occlusal wall again.
Okay, thank you. Another question, will sodium hypochlorite irrigation affect the remaining vital radicular pulp?
In pulpotomy?
Yeah, I think that's what they're referring to.
Not that I'm aware of, no. But you have to use it because you really want to, again, just avoid any bacterial invasion. So.
This is another question. Thank you, Marie-Sophie. I agree. We both do it. Everyone does it regularly in the department, and we haven't had an issue as of yet. I mean, teeth go non-vital for other reasons. Is there a guideline as to who is responsible in admitting the patient in case after a simple day surgery stats go low and the patient is advised to be admitted as an inpatient for further monitoring? I suppose the guideline is based on hospital protocol. I imagine it's I don't know if you guys have anything else to add to it. It's potentially slightly beyond the remit of the webinar, but if you guys have anything, we'd be more than happy to help, of course.
So I think I assume you mean if there are any potential complications with the treatment that was done during the general anaesthetic, then who's responsible?
So responsible is, so it says that if there is guidance as to who is responsible in admitting the patient in case after a simple day surgery. So I imagine a complication after the procedure in the way of general anesthetic. who's in charge of the admission process?
Sure. I mean, this happens really, really infrequently, but it doesn't never happen. And we have had instances where simple day case GAs have had subsequent complications. Ultimately, if it is a dental patient and a patient that we have seen and treated, I think we do have to obviously take some responsibility for ensuring that that patient gets the necessary aftercare. Obviously, we're extremely lucky working in the hospital that we do work in. We have a lot of colleagues who will sort of help with this sort of thing, who we can get advice from. Sometimes it will just be, depending on what the complication is, going to the medical team, just asking for help. If there's a specific complication, getting in touch with our anaesthetic colleagues. But essentially, I think it is important for, if we have done treatment on that patient, to definitely take responsibility in ensuring that we're following up that care and providing the care that they need.
Thank you, Shazia. Just a point of clarification, on the side of local anesthetic, you mentioned no ID blocks with blood thinners. This is not a protocol I am familiar with. Can you clarify?
So I think it's not contraindicated for sure. And I think actually if we look at the guidelines out there, especially the SCDEP guidelines on anticoagulants, there's nothing to say that we definitely shouldn't give ID blocks, but we do know that especially people with more sort of congenital bleeding disorders who may be at risk of bleeding do have the risk of sort of bleeding within the tissues with an ID block, and that can sometimes present quite late because we obviously sort of can't really see it. So they generally suggest that if you can get away with the buccal infiltration, then that's preferable. But if you do need to do an ID block, I will almost always just do them slightly slower. I know we talk about sort of try and avoid as much trauma as possible. Hopefully we always do that. But specifically with patients who are at risk of bleeding, just a very, very slow injection technique, I tend to find, and I haven't come across any issues with that.
And also with aspiration, just to make sure that you're not in the vessel.
Absolutely.
Thank you. Question for Marie-Sophie: is the success for permanent molar pulpotomy the same for immature and mature teeth? And what is the success, as a follow-up question?
So I don't have by heart the success rates. When I was listening to Shazia and reading the question, I saw this question. So I was trying to look on PubMed, but I hadn't the time just to do the literature review. But I'm glad to do some research and to go back to you, Ahmed, so that you can just share the answer.
Yeah, I think that it's very high actually. So just as part of the MClin in Endo, we've just had 3 days ago a lecture by Prof. Manocci, who is an absolute expert and seems to have worked everywhere in the world and done endo, and he is hugely pro pulpotomy. So he does recognize that we don't have really long-term evidence because it is quite a newer technique, but of the evidence that we do have, we are talking about sort of the 95 to 96% success rates if they're done well.
Perfect. Thank you.
You want to do it well because you have all the different.
But they do need cuspal coverage. I think that's one thing that came out of the data. It's still important, even if you're not doing a full root canal treatment, for that tooth to have cuspal coverage.
Wonderful. I think that's there was one more question. Sorry. And what factors determine whether you carry out endodontics or extract a tooth? Like caries risk, standard of oral hygiene, compliance with toothbrushing, many factors, I imagine. But maybe just a sentence or two on that if we have time.
Yeah, I mean, it's really difficult to sum up in a sentence. There really are so many different things that we need to think about. And I think it's fair to say that, what one clinician may do may well be different from what another clinician do. And there is no definite right or wrong answer, essentially. But yeah, I mean, you know, thinking about what tooth is it? Is it a really functional tooth? Is it something that's high in the aesthetic line? I mean, I've currently got a patient with a mild learning disability. She's 61. She's got a chronic sinus associated with an upper right one, which has previously been root treated and has had an apicectomy. The tooth itself is grade 2 mobile, but she is very aware of the tooth. She has a high smile line. She will absolutely not tolerate anything unfamiliar in her mouth. Even when I numb her up to actually do some cleaning, she hates the feeling of the LA. So I know that if I try to put a denture in her mouth, it's not going to work. So even though it's a very compromised situation, I am working with my endo colleagues to try and get this re-apicectomied and re-RCT'd, because I think it is the right thing to do for this patient, who's actually very, very tolerant, very cooperative under sedation.
Yeah, exactly. It's important not to judge our patients and just assume. You know, I think diving into the details to see whether or not we actually can and should be doing it is vital. Perfect. I think we'll cut it here just to allow people to enjoy the rest of their evening. So thank you again, both of you, very much, Dr. Shazia and Dr. Marie-Sophie, for coming and gracing us with all of your knowledge this evening. A lot of work has gone into this presentation and the prep for it, and we at the ISTH really do appreciate all the efforts, and we appreciate all who attended this evening. Thank you very much. This will be recorded as well, and it will be on our website next week in case you do want to refer back to it at any stage in the future. Please do keep in mind of our future webinars as well. Our next one is scheduled in January, and we will keep you informed about the topic and the specific date. And keep the diary open for some time in the summer of next year, when we'll be holding our annual ISTH conference. And we will see you at the next webinar. Thank you very much, guys, and thank you everyone to everyone who attended. All right. Take care, everyone.